welcome you, Scott, to the group. And on behalf of all of us, thank you very much for taking the time to come and speak to us today.
You're very welcome. So I'm Scott Hurton. I'm a surgical resident at the QE2 hospital, and I'm working with Dr. Molinari on pancreatic cancer research. So I'll briefly do an introduction and then talk about some of the risk factors of pancreatic cancer in a Nova Scotia context, and then briefly talk about pancreatic cancer in Canada, and then Nova Scotia, and talk about some of the preliminary data from our research. So, what is the pancreas? It's a very important organ in the digestive system, and it's often a hidden organ because it's located quite deep in the abdominal cavity. The pancreas is divided into three regions. So we have the head, the body in here, and into the tail. And the pancreas produces juices and enzymes that digest fat, proteins, and sugars so that they can be absorbed by the intestine. The pancreas also produces insulin, which is picked up by the blood flowing around the organ. And insulin is important in regulating the amount of sugar that we have in our bloodstream. So here's a diagram of the pancreas. The pancreas lies right behind the stomach, and here's the start of the small bowel. And the liver would be up here. So it is quite a hidden organ in terms of its location. Pancreatic cancer occurs when there's abnormal cell growth that's out of control, and this results in a tumor. As I mentioned, pancreatic cancer is a hidden organ, and there really is no effective screening tests to detect pancreatic cancer at early stages. And often pancreatic cancer is diagnosed at later stages, as in this situation where we have the tumor right over here, and here's the pancreas. This is a CT scan, and here's the liver, kidneys, and so as you can see, it's kind of hidden behind the liver and the stomach, and is difficult to feel from the outside. So symptoms are relatively silent, and patients usually present with jaundice or turning yellow, abdominal pain and back pain, fatigue and weakness, and weight loss or loss of appetite. About 2/3 of all pancreatic cancers form in the head of the pancreas, and the other remainder form in the tail of the pancreas. The most common type is adenocarcinoma, which makes up about 90% of cases. Then other subtypes are mucinous adenocarcinoma, neuroendocrine tumors, and lymphoma can be all types of pancreatic cancers. As far as the staging, we can break it up basically into people who have a resectable tumor, locally advanced tumor, and unresectable tumor. We'll break up patients in Nova Scotia into groups similar to this when I talk about some of our research so far. So what are the risk factors for pancreatic cancer like in Nova Scotia? Risk factors in general are age, race. It seems to be more common in people who are of African American descent. Smoking. It's about 2 to 3 times more common in people who smoke as opposed to those who don't. There can be diet factors, increased fatty foods, medical history, so people with some complex medical problems like cirrhosis, chronic pancreatitis, diabetes are all more common. Then there are some environmental factors and genetic predisposition, but mostly it's a multifactorial disease, and we don't know what combination causes it typically in most cases. So in terms of age, why it seems to be common in Nova Scotia is we have a bit higher median age than everywhere else in the country. We're the second oldest province, and again, as people get older, the incidence or the risk of developing pancreatic cancer increases quite significantly. This is 0 to 1%, so it starts at very, very low percentages between 0 and 39, and goes up to almost to over 0.8% as we age. So in terms of race, African Canadians seem to have higher rates than Caucasians. And Nova Scotia has a relatively large African Canadian population, has the third highest in the country. So that may be contributing to the rates of pancreatic cancer in Nova Scotia. Again, smoking is quite high in Nova Scotia as well. We have the second highest incidence of smoking in the country. So Nova Scotia is right here, and the Canadian average is here. We're just over 20% of Nova Scotians smoke. It's quite high. So obesity is also a risk factor of pancreatic cancer. I'll just show you. Nova Scotia is right here. Sorry, that doesn't project very well. This is people who are of Aboriginal descent. These are non-Aboriginal people of non-Aboriginal descent, and approximately 23% of patients or of people in Nova Scotia are obese, and over 30% of people of Aboriginal descent are obese. In comparison to the Canadian average, which is just over 15%, and just over 25% for Aboriginal peoples. Another issue is diet. So low fruit and vegetable consumption, and as well higher fat and meat intake. People from Nova Scotia, there's only about 37% of people who are able to consume 5 fruits or vegetables a day, or 5 servings of fruit and vegetables a day, and that's significantly lower than the Canadian average. We're about the same as some of the others in the Maritime provinces, but obviously quite a bit more than those in the north. In terms of pancreatic cancer in Canada, as you may know, the rates of the age standardized mortality from pancreatic cancer has gone down in males a little bit, and has stayed relatively stable, gone down from 8.5 to 7.8 in females. The mortality rates from pancreatic cancer have largely been associated with the decrease in them have been associated with the improved care that's provided to patients who have both resectable and non-resectable pancreatic cancer. Just comparing some of the rates of mortality for pancreatic cancer compared to some of the other major cancers. Pancreatic cancer has a cancer-specific mortality of around 93%, and as opposed to lung, breast, and colorectal cancer. This is something that's many of us know, and it's important to continue to get the message out there about pancreatic cancer and improve the research, increase the research capacity for pancreatic cancer. And again, this is the 5-year survival for pancreatic cancer in Canada as opposed to some of the other cancers. Thyroid cancer is the highest at 98% survival at 5 years, and around 9.1% for survival for pancreatic cancer in Canada. So we'll just look at some information about pancreatic cancer in Nova Scotia. We did a review of the literature on pancreatic cancer in Canada, and we found that the 5-year survival for patients, for people diagnosed with pancreatic cancer in different provinces seems to vary. In Canada, the average 5-year survival is around 9.5%, and this ranges from 10.9% in Ontario to around 4.7% in Nova Scotia. Now, this is quite a big difference from one province to another, and although we don't have a lot of the much of the information now, we're still trying to figure out reasons for this. Some reasons may be due to differing reporting strategies. Different cancer registries report their mortality rates in different ways. And so this may account for some of the variability in the survival between provinces. Also, all those things we were talking about before about the higher rates of smoking, higher rates of cardiovascular disease. People in Nova Scotia, as a group, have more medical problems than other people across the country. Sorry about that. And as well, higher smoking rates, and as well as we're, as a province, older than other areas of the country. So this may be a reason for some of the differing 5-year survival in by province. So our current research is to examine the quality of care that's provided to patients with pancreatic cancer in Nova Scotia. Our hypothesis is that patients with pancreatic cancer in Nova Scotia may not receive the highest standard of care. This has been shown across the literature, like in a lot of areas, that patients with pancreatic cancer don't necessarily get the same care compared to some other cancers. There's lower rates of cancer-directed therapy, so like chemotherapy, surgery, radiotherapy, and some of the reasons may be that there's a lack of knowledge of the services that are provided for pancreatic cancer. Also, there seems to be a bit of a nihilistic attitude towards pancreatic cancer. So because the outcomes in pancreatic cancer can be so low, patients may not receive referrals on to see some of these medical specialists. Now, we're not sure whether that's due to the fact that they're not able to go on to get that treatment because they may be too sick at that point in time. But we want to make sure that we describe why these patients are receiving the care that they do. And there's really no literature on the outcomes and quality of care in pancreatic cancer really in Canada, and certainly not in Nova Scotia thus far. So I'll just tell you a little bit about the patient characteristics. We identified 1,161 patients over the last 10 years who have been diagnosed with pancreatic cancer. And the median age at diagnosis is approximately 74 years old. It's about a 50-50 split of people of females and males. And the comorbidity score that we use is just a scoring that's given for each type of medical problem that somebody may have. So, for example, if they had heart disease and renal disease and kidney disease, for example, then they would have a comorbidity score of 2. Okay? Approximately 56% of patients were from an urban area, and 34% of patients were from a rural area. And out of the group, there were 14% of people who went on to have surgery. About 20% of patients had palliative surgery, so either a gastric or a biliary bypass. And there were 61% of patients who received palliative medical therapy. The tumors were found in the head of the pancreas about 45% of the time. In the body or tail of the pancreas about 16% of the time. And now from the cancer registry, we don't have like specific stages as you may have heard of before. They just categorized it as localized disease, regional disease, so in the area of the pancreas, and then if anybody had any metastases or nodal involvement, lymph nodes that have cancer in them. And then about a quarter of people, we didn't know what their stage was at presentation. So although 63% of people were referred on for surgery, only 14% of people were able to undergo a resection. And we haven't really identified the reasons yet for patients who are the other almost 40% of people don't get referred to surgery. So whether they're not at the point where they could have a surgery, or whether it just takes too long for them to get a referral. We're not too sure as to why what the reasons for that are. One of our future areas of research is to look at the group of patients who didn't present with metastases or distant sites involved, and try to figure out what their characteristics are. And through looking at their characteristics, we may be able to find out some of the reasons why they may not have been referred on for resection or didn't receive resection. So for those who had surgical resection, the most common procedure was a Whipple procedure, as many of you may have heard of before. A distal pancreatectomy, which is basically taking off the tail and a portion of the body of the pancreas, was in 22% of people. And a total pancreatectomy was performed in 4% of people. So in those who had palliative surgery, anybody who had, for example, obstruction from their tumor either in their bowels or in their bile duct. They may have received a gastric bypass or a bile duct bypass. And 40 of those people who received palliative surgery, 49% of people got both a gastric and bile bypass, and then 38% and 13% of people had a gastric and biliary bypass. There was a relatively low referral in consultation rate for medical oncology. From the resected patients, about 60% of people were referred on for chemotherapy. In the past, people who had negative surgery margins or had negative lymph nodes, if they didn't have any cancer left that they could see after they examined the pathology once they had removed the tumor, then those people in the past were said to be cancer-free. And so since that time, in the early 2000s, there have been studies that have shown that people who received chemotherapy, even when they had negative margins and negative lymph nodes, that they got a benefit from. The question was, there has been, I had mentioned earlier that I'll just go back to this slide. So on this slide, the age-standardized mortality has decreased, but it has decreased more in the males than in the females. So it's gone from 12.9 down to 9.8, whereas in females it's gone down from 8.5 to 7.8. One thing that I didn't mention was that the smoking rates in males has dropped more significantly than in females. So, yeah, thank you. All right. Okay. So over the past 10 years, these are the survival rates over 5 years for people who received surgery, is around 17.6%. For people who had palliative surgery, it's around 0.5%. Now, these are often people who present with very late stage disease and need these interventions to help them feel better. And people who have no surgery is approximately 2% over 2% over 5 years. Of all patients, our actual 5-year survival is 3.9%. Now, these are a lot of numbers, and this information is really quite early in our study. We basically just have a very small amount of information at this time that we can talk about, and we'll have a lot more information once we analyze all of this data further, and we'll, in a year's time, we'll be able to comment a lot more about the quality of care that people are receiving in Nova Scotia. I'm currently looking through a lot of charts and trying to find out information about the stage of presentation, when and where they were treated, how they were diagnosed, whether it was by a CT scan or an ultrasound or an MRI. And at that point in time, we'll be able to make further conclusions. But I imagine we'll probably have more questions that will need to be answered at that point in time. So I'd just like to acknowledge Craig's cause for helping fund the Pancreatic Cancer Registry. And then there have been several other people who have funded my research with Dr. Molinari. And I'm working with Dr. Molinari, Dr. Jeff Porter, and Dr. Levy. He's an epidemiologist, so does a lot of research with numbers and how diseases affect populations. Repeating, the comment was initially that it would be interesting to see how diet factors across the country affect the incidence of pancreatic cancer, and as well the comment was made that it would be interesting to see globally how that affected the rates of pancreatic cancer.
Early detection. What's happening there? I know that's.
Yeah. Well, I don't know a lot of information about the early detection. There have been some screening programs that have been developed for people who are high risk. So people who have some genetic predisposition for it. So if they have, for example, the BRCA2 gene has a higher incidence of pancreatic cancer, as well as a number of other genetic factors. So some strategies have used imaging. So endoscopic ultrasound has been used. So they use a scope and go down and look at the pancreas with an ultrasound from the inside. So it's just a little bit closer than going through the abdomen, and this just allows for better detection rates than with the transabdominal. But I haven't seen any research on this specifically yet, but there's a 15-year-old down in the States who has developed his name's Jack Andraka. So he's developed this carbon nanotube detection test. Yeah, the mesothelioma. Yeah. And so I'm not sure exactly how it works. That's not my area of expertise, but it's quite interesting for not only pancreatic cancer but ovarian cancer as well as another area. Yeah, mesothelioma. Yeah. And the familial or genetic cases only are typically about 10% of the cases of pancreatic cancer. So it's not, although we can provide screening for that group of people, we don't have the opportunity to screen for others in the population. Yeah. Sorry, the comment was that we could do with this test that actually only costs a few pennies. We could do imaging on a lot smaller scale, do it on less people, but focus it on people who are at risk, more at risk from the blood test. Yeah, I am a surgeon, but
You could just say that.
Yeah. As far as the chemotherapy that I know of, they are trying some biologic therapies. So it's using the immune markers to attack the cancer cells. Yeah, and that's what there's a fair amount of research on that right now, but there haven't. It hasn't been as successful as people had originally hoped. So.